Just one quick slide on observation, and please correct me because I have the least experience compared to everyone. But this is taken from literature and our own observation that we noticed ferritin and CRP were initially elevated for some 6 patients, but some of them move in the opposite direction, especially ferritin. At least in the literature from the early Wuhan days, they say it's not a good indicator for outcome because some patients with level of 3,000 did well, and others levels below 800 struggle. So although high serum ferritin was a predictor of mortality, there were wide ranges in survivors. So that was another issues. And using just lymphocyte count to show mortality has, I think you all probably agree, some of them remain low even as symptomatic illness resolves. So this is something that we used when we had COVID patients for the medical officers to decide who are the one that we are worried about, ICU and non-ICU. But this was early February. I can't remember where I got this reference from, but this is what we adopted when we had COVID patients early onwards. So I want to show you what we use for our medical officer initially. Only 2 studies I'm going to show. This and what I think we should adopt later. So this is what we used. This was 200 over patients from Wuhan, and about 208 patients, 40 progressed. This is a simple one because everything simple must have an internet where they can just click it and score the calculator results. So this is the website. Okay, and this is the mnemonic call. So CALL. So based on comorbidities, age less than 60 or more than 60, lymphocyte more than 1,000 or more than 1,000, and they have this LDH here. All right. So the thing is, it is meant for a negative predictive value, not positive predictive value. That means even if it's above 6, doesn't mean that the patient is going to progress. And we notice in our own cohort, just because they are above 6 doesn't mean they're going to progress ourselves. So the positive predictive value from their studies was only 50%. So what we used it for is for those below 6, the negative predictive value is 98%. So anybody below 6 during our morning rounds, we usually don't bother them. We don't usually worry about them because we think their mortality or they only have 1.5% risk of developing severe COVID. So this is what we adopted initially in our one, and they have another one where they want for ruling in purposes, they have 9. So if anybody reach 9, their sensitivity drop, but their positive predictive value goes up to 78%. So this is what we've been using for some time. So somewhere in May, this one came out. I think I looked at all the COVID calculators that is available. This is the most robust that came out in May. So this is actually risk stratification. Sorry. Risk stratifications of patients admitted to hospitals using the WHO clinical characterization protocol. And the simple mnemonic is the 4C mortality. 4C mortality. So actually it's 35,000 over patient done between February to May in about 260 hospitals in UK. The beauty of the study is they also did a validation cohort, not like the initial call calculator where they didn't have any validation point. This one also had a validation one. Again, they have a website for calculation. So they use 8 variables, the age, sex, comorbidities, respiratory rate, oxygen saturation, GCS, urea, and CRP. So a bit difficult because CRP might be a problem in certain places. So based on that, they have come out with a low risk calculator, low risk, high, intermediate risk, high risk, and very high risk. This is what I put. It's not in the reference paper. I just put this as outpatient. So low risk 0 to 3, their mortality rate is 1.2, very good sensitivity and negative predictive value. So this, if one day we have to treat patient as outpatient, this may be the group. Some hospitals where you can put patients in the ward, the intermediate risk is 4 to 8 with a negative predictive value of 90%. They have scored the mortality rate as 10%. Some consideration of people who needs to intermediate care or high dependency ward, the mortality rate here is 31%, points between 9 to 14. The negative predictive value has dropped. And here, the very high risk, those above 15 points, the mortality rate is about 62%, with a positive rate of 61%. So I think most of this is easy, probably because, it's more clinical, except for urea and CRP. They really went all out with the validation and sensitivity and specificity. So they even have ruled out mortality and ruled in mortality. So you can look at the negative predictive value is quite good, and the mortality rates are here. So based on that scoring, and if you want to rule in, you can also look at their mortality here. So I think most scores are meant for sort of ruling out rather than ruling in. And so the reason why I say this is probably the best in the market is because beside the validation cohort that they did, they also compare with all other mortality scores that is available at that point. And of course, they came out at tops at the moment here with the area under the curve as the highest. So I think it's doable. That's all I think. I have my slide. So I think it's doable. If you want to look for the best, it's also in the website where you can just click in the numbers. And this is so far from all the other calculators. That's all, Dr. Suresh.
Yeah, so I'm just going to give, it's just 5 slides.
Yasmin?
Yeah.
Introduce yourself.
Okay, Yasmin from Sungai Buloh. I'm just going to present a little bit on background of favipiravir, just one slide, and followed by a few studies that I have summarized it in the form of a table. So I left out case reports and case series, and although poorly designed, so I included a lot of some RCTs and open label trials. So a little bit, there's currently actually 37 clinical trials which are actually ongoing, and 3 of them have actually completed the, sorry, I'm just gonna, right. So 3 of them have actually completed, but however, we don't have any results published yet. But we know a little bit about favipiravir because it is actually approved since 2018, and even 2014 was actually used in China and Japan for influenza treatment in those who did not respond to that. And they clearly say it works best when you give it early. And certain reports have also said that it's a bit virucidal. So it's a pro-drug, and it has got a very short half-life, but very good bioavailability. So oral is fine. There's an IV form as well in China. And it's 50% protein binding. It's both dose dependent and time dependent. So dose and frequency does matter when it comes to favipiravir. And it's an inhibitor of the CYP system. So the first 2 studies that was published actually came out from China. The first study is an open label controlled study in China, where they took 80 people. But they excluded severe groups. So they excluded severe group. They excluded patients with comorbidities. Even if you look at the profile of patients, not many actually have, many only have 1 comorbidity, and that's also less than 20% of the group. So they're well patients, and they were all, they were included if they were less than day 7 of illness. 41% of them were around 45 to 61. These patients were actually given favipiravir, and they compared it to a historical cohort group who were on Kaletra. So the dose of favipiravir that was actually used is about 1,600 BD and 600 BD for 1 day, and then 600 milligrams BD following. Some went up to 14 days, but a median time of giving favipiravir was about 11 days. Although clinical improvement was, so this actually showed median viral clearance time was actually shorter in the favipiravir group, and at day 14, it actually showed a good CT improvement. So they did CT scans at day 4, day 8, and day 14, and they saw there was significant improvement at in the radiological improvement at day 14. About 91.4% of them better compared to the control group. And these improvements were actually better as another post-hoc analysis when they did, they saw that the improvement were actually better in those who had earlier viral clearance in favipiravir. Second study is also another study from China, here, they not only looked at the clinical outcomes, but they also studied some plasma concentration. But plasma concentration was not really, but this study didn't have much outcome. So they said none were actually statistically significant. But basically, it's a 1-to-1-to-1. So favipiravir to control to baloxavir, which is another treatment that they were using experimentally for influenza. Median age was about 58. They excluded malignancy, renal failure, and patients with liver disease and COPD. Most patients' time to randomization from symptom onset was about 11 days. And mostly had mild illness. Mostly had mild illness. But when you look closely at the intervention group, you can see that the intervention group had a higher CRP on arrival. And but this is plus standard of care. And their standard of care is huge. So the control group actually got Kaletra, darunavir, arbidol, and inhalation interferon. So treatment group was favipiravir. So they only added on favipiravir or baloxavir. So, they had a huge cocktail of drugs that were actually given to them. And the dose of favipiravir that was used was similar to what we were using before. And none was statistically significant whether it's clinical improvement or clearance of virus. But you can actually see that clinical improvement at 22% was actually seen at day 7 and 55% were actually seen at day 14, but a similar finding across the board. No difference in viral negativity. But if you look at the favipiravir group,
tak boleh pakai phone ni lah. Banyak orang nak call.
Sorry, can I go on? 22% of them developed respiratory failure. Another earlier study that came is where
sorry, Yasmin, hold on. As usual, your speaker is on. Okay, go ahead.
Okay, so three studies were published earlier. So favipiravir versus arbidol for COVID-19. This is another study that came out of China where the patients were actually randomized if symptom onset was less than 12 days. Arbidol versus favipiravir. And again, their standard of care included a lot of immunomodulator drugs, including steroids, antiviral, and even traditional Chinese medicines. This also showed a tendency for clinical recovery earlier in the favipiravir group as compared to arbidol group, and the fever resolved faster, so earlier resolution of fever and cough, and that was statistically significant. And about 18% failure, meaning they actually needed oxygen. Another report was actually from Japan. This was more of an observational study, and they had no comparison group. So they basically took 407 hospitals and then gave everybody favipiravir, asymptomatic patients, for which 45% of them had mild disease, 43% of them moderate disease, and 10% had severe disease on the day of recruitment. And they looked at the clinical outcome 7, 14, and day 30. And if you look at this here, in the clinical outcome, clinical improvement, about 73% of them, the mild disease did well, moderate disease also did well, but about 40% of them on severe disease actually eventually required oxygen. And on 14th day, about almost 60% required oxygen. So this one, they said clinical worsening was actually seen more in those who are more than 60 years old, where mortality was about 20.8%. Less than 59 years old, majority of them did well, although eventually they required oxygen. This is a paper from Russia. This is a study which is still ongoing, and currently is phase 3 trial. Here, this is interesting, where phase 1, about 60 patients with moderate disease were actually randomized to high dose favipiravir, low dose favipiravir, and standard of care. All right, they did not write down what their standard of care was in this trial, but their aim is basically looking at viral clearance, progression needing oxygen, and resolution of symptoms. High dose favipiravir is currently what we're using right now, and low dose is what we're using previously. So clinical improvement, prelim observation about, again, viral clearance and resolution of fever was actually seen less than 5 days in these patients. So favipiravir, afebrile by day 3, and viral clearance about day 4. And other results are actually not shared yet. This is another ongoing analysis that was in India, where they actually looked at favipiravir use in mild to moderate COVID, and looking at clinical improvement, resolution time needing oxygen, time to discharge, cessation of viral shedding. And this is currently the favipiravir has been approved in India for use for COVID-19. And here again, they saw early viral clearance, faster, early viral clearance, resolution of fever faster, and compared to the standard of care arm. Istanbul is another one. It's a preprint thing, and this question, they were trying to answer 2 questions. One of those questions is hydroxychloroquine, azithro, or favipiravir plus dexa is more effective? And they recruited all symptomatic patients with mild to severe disease, and about 14%, 12% of them actually had severe disease. And there was actually no randomization in the study, but the treatment was actually done at different times. So it's like a historical cohort or ongoing cohort who were initially given hydroxychloroquine, azithro. They saw a lot of failure with hydroxychloroquine, azithro, and eventually everybody was actually switched to favipiravir plus dexa. All right, and the favipiravir group, although 25% of them eventually developed pneumonia, and about 28% of them developed treatment failure, meaning needing oxygen. Another group was, so there were 3 groups. One is hydroxychloroquine, azithro, favipiravir alone, and the third group is favipiravir plus steroids. The group with favipiravir plus steroids actually did well, and no mortality was seen in this group. This is a case control. These are case reports, but I just wanted to highlight that favipiravir has been used in the current dose that we're using in patients of end-stage renal failure undergoing regular hemodialysis. There are no studies on patients with impaired renal clearance, but these case reports basically said there were good outcome, no adverse events were seen. Even if there was a slight increase in liver function test, the minute you stop the favipiravir, it goes away. And of course, and they also looked at the plasma concentration of the blood, in the blood, plasma concentration of favipiravir active metabolite in the blood, and they said it was similar to someone who doesn't have end-stage renal failure. However, no clinical details were discussed. This is my last slide. However, I think at this moment, nothing is statistically significant, but higher dose is tolerable. Faster clinical recovery, not inferior, and resolution of symptoms compared to standard of care has been seen in many studies. Some studies show faster viral clearance by day 5. About 20 to 28% progressing to category 4 is actually seen in various studies, and it's got a good tolerability profile even in end-stage renal failures.
Okay. Okay, I talk about interferons, and actually not many studies until the Solidarity trial. This is the Hong Kong paper that earlier on we have already discussed, that it shows some benefit in terms of time to negativity, new SOFA score for clinical improvement, and shorter hospital stay. And that shows more benefit among within 7 days of onset when we give combination therapy, especially from interferons is given in the arm. This is just to show that the improvement in various aspects. And you can see that if given early, the interferon arm combination actually reduce the viral load in the first 7 days of symptoms. After 7 days of duration, they did not give, so they cannot conclude much from there. So after that, there are actually just like 2 more studies talking about interferon, and this is from Cuba, in addition to Caletra and chloroquine. However, there is quite a few limitations in this study. That is non-randomized, and it is not equal in size that the interferon arm is 78. No interferon is only 53. And even though they concluded, you can see that all interferon arm, a lot of them 95% discharge, the case fatality rate is low. However, it is not balanced between 2 arms, and they only analyzed only 20 3% of their patients. A lot of them are still hospitalized. So, and main thing is the limitation of their comorbidities and the years of the patient, age of the patients, 66 versus 42 years old. So for me, this is not a very good paper to make a conclusion. I'll skip this because this is very small numbers of 20 patients only. And then I'll come to interferon in addition to hydroxychloroquine and Kaletra, atazanavir, ritonavir. This is from Iran. They have about 90 patients in both arms. And this study started to show that that there's no difference in time to clinical response, length of stay, and so on and so forth, preventing mechanical ventilations. Even though in the end, 28 days mortality was lower in the interferon arm, but because that arm contains 4 patients who died before the finished the course, so they excluded the analysis. So it's very difficult to interpret that. So again, there's no difference overall. So coming into Solidarity trial, so it is the second largest arm that contains a patient of about 4,000. So you can see 2,000 in the interferon arm and the control, about 2,000 same. And a smaller number in combination with lopinavir and a larger number that without lopinavir. So they give 6 days, 3 doses. And in fact, they have stopped it since 16th of October. So from the result of Solidarity trial, okay, so to the left is better, and to the right is worse if given interferon. So split into different age group, whether it's younger or older, and even when patient came in ventilated or non-ventilated, they are all towards the a tendency to be more worse when given in the interferon arm, whether combination with Kaletra or alone. And so they put into statistic of rate ratio RR, it is 1.16. If without lopinavir co-administration is 1.12 rate ratios. And of course, there may be questions about is there a steroids which can be given that affects the mortality in any of the arm, and they mentioned that the half of the interferon patients and also their controls actually receive steroids. So it doesn't seem affected by giving steroids. From NIH US updated in the end of August, they actually recommend against using interferons alpha or beta for the treatment of severe patients, critical patients, except in a clinical trial. Insufficient data to recommend against the use of interferon, even they are in early, including less than 7 days of symptom onset. Just coming to the end, also mentioned in the, there are options of nebulized or inhaled interferons. This is from China. It's uncontrolled exploratory studies. There is some positive signals from the studies, including reducing the inflammatory markers, as well as a recent press release by UK that inhaled interferon versus placebo seems to have improvement in terms of recovery clinically, and also less breathlessness and developing severe disease. However, more detail and studies is required for that. Lastly is about interferon lambda, in which several countries, including Israel, Canada, and US, is under recruitment, comparing to placebo. So with that, I summarize that a few studies that support interferons from Hong Kong initially, followed by Cuba, Iran, but there are a lot of limitations from these papers. And now, recently we have against interferon, which is from a big number from Solidarity trial, and also recommendation from the NIH US, and also the smaller number of Iran paper. So looks like interferon may not be recommended except in clinical trials, and we may have more information from interferon lambda and the NAT inhaled preparations. So it comes to the question whether interferon shall we continue or remove in view of the high cost and yet lack of advantages in preventing mortality and mechanical ventilation.
Cream, I only have a few slides. Okay, so everyone knows this, why TOSI is being advocated to be used in COVID-19, mainly for the cytokine release syndrome. And IL-6 is found to be the major driver for this cytokine release, CRS or cytokine storm. So just a reminder, TOSI is an anti-human IL-6 receptor monoclonal antibody. So theoretically, it binds to the receptor and stops any immune damage that may happen. So I'm just going to go through a few. There's a lot of papers out there, obviously. I'm just going to go through a few that I felt were quite important to put forward the argument of whether we should use it, how we should use it, and so on. So this is just a review by some authors, which was published in September. So they didn't do much statistical analysis on this other than just to collect about just under 20 papers to look at what's the evidence for TOSI with regards to respiratory inflammation in COVID-19 patients. So the overall impression is TOSI may have a positive effect on improving immune damage. And the papers, as you can see here, the majority of the papers showed favorable outcomes, but take note that it's a mixture of clinical trials, case reports, retrospective studies, and so on. And they sort of quoted just under 20 papers, if you like. Just pulling out one or two papers from that. So this is a retrospective observational cohort early on in the pandemic. And what they found is they felt that there was a trend association towards reduced mortality among ICU patients. However, this paper, again, another retrospective analysis cohort where they did a propensity score match cohort. And in this paper, there were 18 deaths in the TOSI group and 18 deaths in the no TOSI group. So in this paper, based on this analysis, they do not support the use of TOSI in the management of cytokine storm. This is a systematic review from people from Stanford University, which came out in September, but this is not a peer review paper. So what they did is they looked at clinical studies to date with primary data on tocilizumab treatment for severe COVID-19. They found 16 case control studies and 18 uncontrolled trials. Out of the 16 case control studies, the overall impression is that in all but one of the studies, the odds ratio of mortality pointed towards lower fatality in tocilizumab versus standard of care. And the random effects odds ratio was 0.453. The uncontrolled trials, nothing much to say there except for they did just a qualitative analysis where the raw combined mortality rate was 16%. The biggest caveat in this paper is they couldn't include any prospective RCTs because there were none. And this was after the data from this is after Roche stopped the study on Covata, which I'll be speaking about a bit later. So this is the list of studies that they had, and this is the total random effects in terms of mortality. Just a few points in terms of tocilizumab. So this particular, again, retrospective study showed that patients who received tocilizumab, they had lower mortality rate, but they did see a higher superinfection occurrence. But saying that even though patients who had TOSI had a higher infection, of bacterial infection, if you like, the mortality rate was not increased despite having this secondary infection. So this is another retrospective cohort. So in this case, again, they matched patients who had TOSI and those who did not receive TOSI. And in terms of mortality, there was a lower mortality rate in patients who had received tocilizumab. And in this paper, they actually looked specifically at CRP. And they found that this effect is mainly seen in those who had a higher CRP compared to those who had lower. So suggesting that TOSI may be useful in patients who require ICU support in terms of mortality. This study is quite interesting because it's not the RCT, but they actually looked into different groups of patients. So one had TOSI, one had intermediate high dose of corticosteroid, one had a pulse dose of corticosteroid, combination therapy, and no clinical indicative of hyperinflammatory state. So I don't know whether you guys have heard of the STORM study. So in a way, this is sort of reflecting between TOSI versus steroids, if you like, and was given early on, less than 2 days after day zero. Day zero being the day that they determined that the patient was having a hyperinflammatory state. And in this group of patients, they saw that patients who received TOSI had lower hazards of intubation or death. Patients who received pulse therapy of steroids, so higher doses of steroids, also showed some improvement or lower hazards of intubation and death, but there was no benefit seen in those who had intermittent high-dose corticosteroid or combination therapy in terms of outcomes. So tocilizumab may be useful in this patient who had hyperinflammatory state, and also patients who received pulse dose therapy of corticosteroids. So the COVACTA study was supposed to be the first phase 3 randomized controlled trial looking at giving tocilizumab versus placebo and also with standard of care in hospitalized patients. So the inclusion criteria was very broad: hospitalized with COVID-19 pneumonia, evidenced by chest X-ray or CT scan, and hypoxia. And the primary outcomes was actually clinical status at day 28. So at the end of July, Roche came out with a press release saying that they were going to stop the study because it did not meet its primary endpoint, and also the secondary endpoint of reduced patient mortality. There are still some studies going on, but for this study per se, they've stopped it. But unfortunately, until today, we still haven't seen the full data published yet. So some commentary regarding COVACTA. So a lot of researchers were actually a bit worried about this because they felt that, it might halt any further evaluation of tocilizumab versus other immunomodulators. They felt that COVACTA may have failed because of the study's broad patient selection criteria, the timing of giving the tocilizumab, and also when the patients were assessed in terms of outcomes. So it may not be a very good study, but as I said, the study itself has not been published for us to look into the details of it. Another randomized controlled trial, Corimono 19, may be a little bit more promising. So this particular platform is looking at various immune modulators. So again, it's not published yet, but a press release has been issued saying that in the open label RCT of tocilizumab, they found a significantly lower proportion of patients reaching the primary outcome in the tocilizumab arm. So again, as I mentioned, this has not been published, but just as a press release to show that it may have some promising outcomes. So take home message. So tocilizumab may be useful in patients with pneumonia and also evidence of cytokine storm. So it should be guided by clinical presentation, especially the SpO2 and also CRP. There are many observational studies out there, most of them showing positive effects. Very scarce RCT, the failed COVACTA, hopefully that won't put a halt to further RCTs. Promising Corimono, but there are many RCTs in the pipeline currently. Dosage and route, so the majority had 2 dosage, either 400, 800 or according to weight, but there were also some studies that use subcutaneous instead of intravenous tocilizumab. So timing of using tocilizumab, so with the release of the WHO guidelines based on the recovery trial, it sounds like TOSI might be pushed back as salvage therapy, but I would like to argue that I feel that TOSI should be on par or given as either one. So either DEXA or DEXA or steroids or tocilizumab when there is evidence of cytokine release syndrome in patients with COVID-19.
So I think made my job easier because IDSA summarized everything for me. So they summarized the WHO REACT group, their meta-analysis. The 28-day mortality was, even in the steroid arm, was 222 deaths. I always wondered how come there are so many deaths in the steroid arm. When I went to Tau, I realized why there are so many deaths in steroid arm. And the usual care was 425 deaths, and so summary also is 0.66. And they look at dexamethasone, hydrocortisone, and methalpred, all the studies. Dexamethasone technically became more significant purely because they had the numbers, but similar odds ratio, and so many people think it is a class effect and not purely a dexamethasone, a methalpred effect or dexamethasone. And there's one study that looked at CRP levels and showed that if CRP is more than 20, then steroid has got benefit. But if CRP is less than 10, if you start, then there is more mortality. As Sharifa just mentioned, most people go for just hypoxia. But if we have CRP, maybe we could fine tune it better. Because I feel some of these CRP less than 10 requiring oxygen, we realize actually fluid overloads or cardiac failures, not COVID pneumonias, and we were giving them steroids. And so using CRP is still a good marker. And then that's regarding that, right? So all we have is steroids are useful, and everybody goes back to the dexamethasone 6 milligrams as a dose. And the 6 milligram dexamethasone dose, even in the recovery study, was very high mortality rates. And I don't think we can accept the mortality rate in recovery study as our standard. And so I was looking at alternative methods of dosing. There's a review article that was from the guys in St. Thomas Institute. I'm told by the doctors who work in UK that there's a very renowned Center for Critical Care Medicine as well as respiratory supports. And they published this paper before even recovery study. They said in an early stage, they give 1 milligram per kilogram per day, while in late stages, people coming to them late, they give 2 milligrams per kilogram per day if late. So somebody is now first time saying that, the dosing has to be tailored to how advanced they come. Late stage, higher dose, early stage, lower dose. And then there's very controversial EVMS critical care protocol that also talks about vitamin C. Again, they say the same thing, they say methylprednisolone 80 milligrams loading dose, then 40 milligram 12 hourly. But if the CRP is increasing, double the dose. From 40 milligrams 12 hourly, they give 80 milligrams 12 hourly, and even 125 milligrams 12 hourly, and sometimes they used to give 250, 500. So what they're trying to say is you need to tailor the dose based on the patient's clinical condition. And number one. Number two is if the patient is not responding, you might probably double the dose. So the question now is, do you double the dose of steroids or you give tocilizumab? I think that's a clinical question that we need to answer as study. Okay, so I proposed this that we use 6 milligrams OD or 4 milligrams BD, either of those two doses. And if BMI is high, use 4 milligrams 3 times a day. But if somebody comes in a late pulmonary phase, use a higher dose of steroids. Don't just stick to 6 milligrams, because based on our own experience in Sabah, 6 milligrams does nothing to these patients. The CRP is still high, they're still ventilated. But when you give higher dose steroids, the thing comes down. I think later we can ask Giri and Sabah is the opinion too. Just to give you some dosages, if you assume that somebody's body weight is 60 kilograms, 6 milligrams of Dexa is equal to 0.5 milligrams per kilogram methalpred. So that's what the recovery study says. 12 milligrams. We give 4 milligrams 3 times a day. It's about 1 milligram per kilogram methylpred. So this is what the UK paper suggested that we should give for mild cases. And 1.5 to 2 milligrams will be equivalent to 18 milligrams or 24 milligrams of dexamethasone. I think many of us, we have given 8 milligrams 3 times a day. That's about 18 milligrams in patients who have cerebral edema. We have given that. And I think 24 milligrams, I think, are higher. We have only used it in typhoid patients.
Hi, this is Arisa from Sungai Buloh. Can you guys hear me?
Yes.
Yes.
Okay, it's going to be a short presentation. So we've talked about all the drugs that we have used before. So the last presentation will be, shall we try convalescent plasma in COVID-19 management? So just to recap, it's actually a passive antibody therapy whereby we collect the recovered COVID-19 patients' serum, which is thought to contain virus neutralizing antibody. And the proposed use is either for prophylaxis in especially healthcare workers who are exposed to COVID-19, or as a therapy for COVID-19 patients. So any evidence? There's a lot of case reports or case series, but not much strong evidence. CP has been used in the previous outbreaks of SARS, MERS-CoV, so they have been trying this for COVID-19 as well. So the first pilot study in Wuhan, China, where they recruited 10 severe patients to receive CP with neutralizing antibody titers of 1 in 640 or above. The onset of illness to CP transfusion was about 16.5 days, which is less than about 2 weeks, and clinical improvement seen within 3 days. And out of the 10, 7 patients had undetectable viral load after the CP transfusion. No severe adverse effects observed. There's one randomized control trial in China as well, reported in JAMA, where they recruited 103 patients receiving CP versus standard of care, but it was terminated early as no statistically significant improvement in time to clinical improvement within 1 month. How about in US? So there's a reported case under Mayo Clinic for study updates for CP use. This is a project in US where they expanded the access of convalescent plasma. So between April to June, nearly 25,000 patients received a CP transfusion, and they reported 7-day mortality rate of 12.9%. So when should we use CP if it's used? Ideally, it should be timely rescue therapy used within or less than 14 days of onset of illness, because we thought that that is the time when the viral activity is the highest. And who we recommend, WHO recommended the use of CP for those basically category 3 onwards. So we have collaborated with Pusat Darah Negara in identifying donors for CP. So the first donor was referred to PDN in April, and we have recruited about 22 patients so far, and some were repeated donors. The left-hand side are just basic donor requirement for blood donation, but specifically to COVID-19, patients should be asymptomatic at the time of screening. It was before PDN wanted the patients to be tested repeatedly and to make sure that they are negative, but now this is no longer required. And the recruitment can be made at least after 14 days after the date of onset of illness, as long as they are asymptomatic. What are the limitations of using CP? Patients who receive CP will also receive other standard care, including antivirals. So we don't really know whether drug or CP works. Steroid also might interfere with the immune response and might delay viral clearance. In the papers or the case reports, they all are able to measure the viral load, but we can't. So our surrogate that we could use probably are CT values when we send for our PCR testing. And the kinetics of the viremia phase during the first week of illness are unclear, where the time of transfusion and reduction of RNA positive plus optimal concentration of neutralizing antibody and treatment schedule needs to be clarified. Unfortunately for our plasma, we are not able to perform neutralizing antibody titer. So we only know that the donors have presence of IgG, and we are able to measure the IgG semi-quantitatively if the IgG is present, and we will recruit them for convalescent plasma. So CP in Malaysia, as I mentioned earlier, we started since April. Sungai Buloh has been the main recruitment center, and we send them to PDN for harvesting. In a month ago, Kedah has already set up a collection site up north and soon hopefully in Sabah to cater the needs of the region. So how about the experience using CP? Personally in Sungai Buloh, we haven't started any transfusion, but up in Kedah, ever since Siva Ganga cluster explode, Dr. Lo Lili has experience with 17 cases, 12 males and 5 females. The age are between 35 to 82, all were category 4. 10 patients received single, 7 patients received double transfusion, means 2 bags of convalescent plasma, with 2 mortality reported in the 7 patients that received double. However, this was thought that the patient actually presented late and nothing could be done to improve the care at that particular point. In terms of adverse effect, there's only 1 reported mild urticaria after transfusion. Out of 17 patients receiving CP in Kedah, 7 managed to be discharged home, 3 are still in ICUs, and others are still as inpatient but in general ward. In Negeri Sembilan, they used CP about 2 weeks ago, and the outcome is patient able to be discharged home. Penang has 1 patient. Unfortunately, patient passed away after CP transfusion. So just to reiterate again, there are many repetitions, yes. Similarly to other antivirals that we have discussed earlier. So patient receiving CP will also receive other treatment, so we don't know which one works. Unfortunately, we do not have commercial kit to test for neutralizing antibody titer. If it's available, also it's still under IMR evaluation. In PDN, during the first wave, we recruited about 10, and after the recruitment, we harvest the plasma and send the blood, the frozen plasma for semi-quantitative neutralizing, semi-quantitative IgG level. But now since we have RTK antibody available, so we can do that as a bedside test and decide whether the patient inpatient could be potential donors, and we call them back after 14 days. In terms of clinical efficacy, no strong evidence, but it has always been used in critical situations during outbreaks in the past. We also need to think about duration of protection provided by the passive antibody transfusion. It can vary between weeks to months, and how about the long-term immunity of the recipients? So this is subject to discussion, and whether the recipient should be offered vaccination in the future. Also, we in Sungai Buloh itself, we have very limited experience in CP use, and we are also trying to fine-tune our coordination in plasma donation. Thank you.